Thanks everyone for joining us. It'll take about a minute for Zoom to add everybody to the room, so we're just going to hang tight until that happens. Thanks everyone for joining us. We're just giving it another few seconds to give Zoom an opportunity to add everybody who registered, and then we'll get started. Thanks for your patience. Okay, hopefully everybody has had an opportunity to join us. We will go ahead and get started. Thank you everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic. I'm Gregory Phillips with Duke Communications, and I'll be moderating this panel. We have two Duke scholars with us today to discuss the implications of states pressing forward with reopening plans despite a continuing increase in hospitalizations from COVID-19. I'll introduce our speakers and get the discussion started, then we'll open it up to questions. We are recording this briefing, and that recording will be sent to everyone who registered. Thanks also to those of you who are joining us on YouTube this morning. Thanks to reporters who already submitted questions. During this discussion, those of you joining us on Zoom can submit questions via the Q&A window as they occur to you, and there will also be an opportunity to ask questions in person in a few minutes. So I'll move on and introduce our panelists. With us today is Dr. Sallie Permar, who is a professor of pediatric infectious disease, immunology, and molecular genetics at the Duke University School of Medicine. Good morning.
Good morning.
And also from the School of Medicine, we have Dr. Cameron Wolfe, who is an associate professor and a specialist in infectious diseases. Good morning to you.
Hey, how are you? Good morning.
Good, thank you. And Dr. Wolfe, we'll start with you. Since the start of the pandemic, hospitalizations have been rising steadily in this state and others. And North Carolina reported a record number of COVID patients in hospitals yesterday. How much of a difference do you think reopening has made to that trend?
Yeah, it's a great place to start. I mean, hospitalizations has almost for me become the one indice that I think I can weight the most significantly when I think about our COVID sort of prevalence across the state. You know, we hit 846 admissions yesterday, which, as you say, is a new sort of high watermark, and that trend has really been sort of linearly increasing over the last really couple of months. And yet it's been challenging because it's such an even increase that it's hard to necessarily pin down one specific phase of our state opening to necessarily correlate with that. I think it's a little more complicated than that because many of us, frankly, are really starting, I think, to see some fatigue in the community. And I think that fatigue expands many things that we know controls this virus. It extends to mask wearing, it extends to social distancing fatigue. And so those things have played into disease transmission. I'm pretty certain of that. And unfortunately, the sort of phased reopening has just sort of, I suspect, encouraged a little bit of letdown of folks' guard, for want of a better phrase. And so you really are seeing that sort of steady march of increasing cases and increasing in hospitalizations. And we've got to figure out ways of turning that around. That's very much the answer.
Absolutely, thank you. Certainly a lot to dig into there, and we will get back to that. But for now, I'd like to move on to you, Dr. Permar. You've said that children are the key to the COVID-19 endgame. Why is that?
Yeah, so being a pediatrician, I often think about what are going to be the impacts on children now and for the future, because they are the ones who are going to be living with the impacts of this virus the longest. And, you know, one surprising aspect of this pandemic has been that it's a respiratory virus where children are not often severely affected during the acute infection. And that's different than many of the respiratory viruses we deal with, like influenza or respiratory syncytial virus. However, one thing that has been very new and still developing is seeing this post-infectious syndrome that happens almost exclusively in children, where there is an inflammatory syndrome that can be very severe, can land children in the hospital, or it can just give them a fever and a rash. And we're still really understanding what that post-infectious syndrome is, what it means for their long-term health. But I think it has reminded us that children are not completely unaffected by this pandemic. And, but we know that despite them being a minority of the hospitalizations that Cam just talked about, they have been impacted majorly when it comes to things like their development, their education, and even their routine healthcare that has fallen behind during this time. And we're having to face the decision of reopening schools, which I want to advocate for, that we should think about children and the child-specific metrics as to whether we're going to open schools differently than how we think about bars or restaurants. And that we need to work quickly to develop measures that are going to be specific to what are the transmission patterns in children, what are the risks for children, as opposed to applying it broadly to the whole community. And then, of course, as we look towards a vaccine, the vaccine is being developed at the most amazing speed. Something as a vaccinologist I never thought I would see is developing a vaccine within a year, and maybe having a licensed vaccine within a year of knowing about this virus. And right now that's being solely focused on adults. And I think we need to consider adding children to that vaccine development as well. We know children are the targets of most of our vaccines, and they get the highest coverage in number of or proportion of children that get vaccinated. They also make very good responses to the types of vaccines that are being developed for this coronavirus. And they, of course, are often routes to adults becoming infected as well. And so adding children into vaccine development, I think, is very important for us to think about now, rather than waiting till all adults have been vaccinated.
Absolutely. Thank you both very much for those introductory answers. We've got an awful lot to dig into here, and we've had a ton of questions submitted in advance. I just remind everybody that's on the call, you can submit questions by typing them into the Q&A window, or you can raise your hand on Zoom. And if you're calling in by phone, you can raise your hand by pressing *9, and we can unmute you so you can ask your question. As I said, we've already had a ton of questions, and we're going to try and get through as many of them as we can. And to start off with, we had a number of questions around the importance of wearing masks. And so one thing I'd like to hear from, Dr. Wolfe, we'll start with you, and I'd like for Dr. Permar to weigh in too. One question we had was, what's the scientific/medical consensus on how important it is to wear a mask in public to limit the spread?
Yeah, it's a good question. And I think it's one that has unfortunately not had as much clarity as I would have liked in public discourse. We've not had good leadership to answer that question so far, to be frank. I think the scientific consensus is actually quite clear. The consensus exists on two fronts. The consensus exists on both types of masks and their sort of protective efficacy, if you will, for the individual wearing it, and also for the collective benefit that we get as a community from me wearing a mask fundamentally to protect you. I think that second part has really not been, I think, emphasized sufficiently. People have often sort of viewed a mask, sort of particularly, we all have our surgical masks here in the hospital, for example, as something that's designed to protect them. And whilst that may be true in a hospital ward, for example, where I'm seeing a patient who's positive, in the community, really the drive is very clearly to protect everyone else. We understand now very clearly that this virus has a pre-symptomatic phase of shedding. And so what that means is, even though I may not be symptomatic today, even though I may have no idea of the fact that I'm going to become sick in a day or two, I may still actually be replicating enough virus in my nasopharynx, in my throat, that I can pass that to other people unwittingly. And so my wearing a mask fundamentally protects you when I don't know that I'm going to be sick or infectious. That part of the science is actually pretty clear. What becomes debatable points, I think, is the kind of mask, the length of time that one needs to wear the mask, and whether it should be a mask that's sort of, there was a lot of sort of early confusion, I think, about everyone trying to buy up N95 masks and should they be allocated to hospital systems. The question in the community is much more simple, I think. The consensus seems really strong to me that the wearing of any mask, including the cloth masks that folks will now see for sale widely, is very satisfactory at me preventing you getting sick And that's the public health part of this that I want people to sort of take away from. When I walk down the street wearing a mask, you know, I'm doing that for other folk around me, not fundamentally for me. That part of the science I think is actually really clear.
Gotcha, thank you. Dr. Permar, would you like to weigh in on that?
Yeah, I totally agree that I think, you know, while it took us a while to land on this, but the data has really shown that wearing a mask and preventing those respiratory droplets, like Cam talked about, from spreading on other people is really effective. And one of the most revealing stories I think that has come out in the last few days about that is these hairdressers in Missouri who were pre-symptomatic with their coronavirus infection, and they saw 140 customers during the time that they were not yet symptomatic, but were wearing a mask, and none of their customers became infected. And that's just one of the most revealing stories, I think, showing that the masks are super useful in protecting those that you are around. And so you wear a mask to prevent infecting others. And also it does play some role in protecting yourself as well. And so when we think about requiring masks and even more complicated question of requiring them in schools, I think it's something that the benefit versus the inconvenience weighs toward the benefit. And so I would support that we continue to require and very much encourage masks throughout the entire community.
You stole my thunder with that story because I think it's perfect, Sally, because if you think about the way that stylist scenario played out, like that is an intimate contact, isn't it, between a hairstylist and the person who they're looking after for that 20 minutes, half an hour, and yet there were no infections. Like that's quite remarkable. You know, that's not just me passing someone on the street walking down, that's me being closely engaged with that individual for an extended period of time, and yet it was preventative. That's such an impactful story to me.
I'm glad, I'm sorry, go ahead.
No, please.
Dr. Wolfe, I'm glad you mentioned the passing somebody in the street, because we've seen, you know, as of tomorrow, the city of Raleigh is enacting a mask ordinance that includes being outside, and many cities across the US have done the same thing. But then the science early on in this pandemic was suggesting that if you are outside and you're say walking alone and you're only occasionally passing other people, then a mask might not necessarily be necessary. What's the current scientific thinking on being outside and not being with the same group of people, walking on trails, as so many people are doing right now?
Yeah, I think it's all a graded risk, to be honest. There's no one red line that you can say, aha, you know, 5 seconds beyond 3 feet is the point at which everyone gets sick. It's not that at all. But I think what you find is that you find the longer you're approximate with someone, the closer and the more intimate your contact with someone, the higher the risk. And so we often draw a line at sort of 6 feet or 15 minutes is often the line that's drawn in public health contact tracing contexts, because that is not only an easy message to describe, but it's a very strong line in the sand by which we think risk is cumulatively high enough that we should entertain the idea about quarantining individuals. But I do want to say that it's, you know, it's not to say that briefer encounters or encounters that are slightly farther away than 6 feet can't have some risk. It's just substantially reduced. So when you can't be so precise, again, it comes back then to the benefit of wearing a mask, because, you know, yes, it's true that hairdresser may have had a cumulatively closer and longer risk to his or her customers. But that's not to say that as I walk past someone in the street that I don't cough at the very instant that they walk past me, and that's the risk. Whereas that cough goes straight into the inside soft material of the mask and gets largely soaked up there. So the lines that we draw for case contact tracing are done in order to sort of wrap our hands around that separate element of public health. The mask guarantees that wherever you are in terms of close proximity or duration of time, you're still offering other people some protection.
And I also think that you know, it's hard to remember to wear a mask, and can be uncomfortable. And so the more you see other people doing it, the more you're going to feel like you need to do it, or maybe you want to do it as well. You know, I think it's an opportunity to show your flair. I know I went out and bought some designer masks. I prefer Lily Pulitzer materials. So I think, you know, everyone can show their personality in what masks they choose. And so it's really an opportunity. And so I think the more we require masks, the more it will become normal in our everyday lives, so that when we're walking down the street, we may want to dash into a store, we may stop and talk to someone. And so just having a mask on all the time makes it easier to remember.
Part of that's about good leadership though, isn't it, Sally? Like in good example setting. That is something that I wish we can do better on as a community. We have almost politicized mask wearing. Like that is some sort of dystopian reality where the wearing of a mask has become something that can be judged. And I think, as you know, as you and I well know, as folks surely in infectious disease need to be setting a pretty good leadership example there. And I know you and your family do, and I know I try hard with my kids as well. But that also comes from leadership. That also comes from political leaders buying into this. That also comes from state and federal politics, political leaders being visibly taking this to heart. That has not yet happened. That needs to change if we're going to get people to buy into this. You can't get around that fact.
Totally agree.
And absolutely, we certainly want to dig into the leadership aspects of this. But before we do, I would like to shift. We've had a number of questions about school reopenings. And Dr. Permar, I'd like to come back to you. The general question that we're getting here is, how much of a concern, you know, is there about another wave, a renewed wave, when schools reopen? And how would you like to see school reopenings approached by state and local entities?
Yeah, so school reopening is a really difficult decision that we're facing ahead. I have said that I'm glad I'm not the one who has to make it. It's that hard. But what I hope is that we will dig into the data. We will dig into the data that shows that children have a very different course of the infection. They are certainly mostly asymptomatic. But what's really important for us to understand is how much do they transmit the virus? How much do they transmit virus to their peers? How much do they transmit virus to staff and teachers that are working with them? And what about when we wear masks? Can we reduce that risk? So it's something that what I hope in the next couple months will transpire is the development of child-specific metrics on this, the state of the virus in our community. How many children who are presenting for routine healthcare test positive when they may have come for not having symptoms, but coming for a routine surgery or something like that? How many children are testing positive in our community might be an example. Another example might be absenteeism for, you know, influenza-like illness. That would maybe be a sign that more children may be having infection than others. So I think what I hope is that the education leaders and the public health leaders across the state can think about schools differently than how we treat bars and restaurants. I think that the appropriate metrics for opening up the community in many places where adults are going to congregate is, you know, number that are hospitalized, number of percent testing positive every day. But I don't know that we should apply those same metrics to children and schools, because we know that as much as teachers try and as much as parents try, the virtual learning will not be the same, and especially for the youngest children who really need that face-to-face interaction to benefit for their development and their education.
Sally, do you know, we're not the first country to go through this question. Do you know if there's been any data yet? It may not be yet. You know, Germany versus Denmark, for example, as nearly adjacent countries, have taken a very different approach to the way they reopened this. Is there any data that says one method is better than the other yet, or is it too early to know?
Unfortunately, it is not yet clear, I don't think, and we are certainly watching those countries that have gone before us, but the reports have been somewhat mixed so far. And often I think when countries do have a new outbreak, like one that was reported in China this week, they go ahead and shut down schools again. So I think it will take more patterns of this to really understand. And of course, we know that what goes on in the US is can be very different than what happens in other countries in terms of culture. How often do we, shake hands or hug as opposed to other cultures? It weighs in a lot. And so right now the data has been mixed, but I think what's clear is that the transmission rates are different than typical respiratory viruses that we worry about. That there's some new reports out that children are often the secondary person infected rather than the primary person who brings it home to a household. There's reports that children younger than teenage years may be infected less often. And so the data is still rolling in, but I think what it's saying is that children are different, and we should then make sure that we have metrics that are specific to them.
Gotcha. Thank you both for that. We've obviously got more to talk about with regards to children, but I'm going to move on to some of the other questions that we've had coming in. And coming back to this notion of leadership, Dr. Wolfe, that you talked about, we have a question from Andrew Joseph, one of the reporters at STAT, who's curious for your perspective on the various policy and response plans at state and federal levels, steps that are being taken and are not being taken. As you've said, attention seems to be fading. People are getting a bit jaded about it, but what specifically, what are some specific things that you think should be happening that aren't at the state and federal levels that could make a difference to this thing?
Yeah, it's a really great question. The way you think about how you sort of I'd be interested in Sallie's thoughts here too. The way I think about breaking down a pandemic and really trying to get it under control, I think good examples of what we've seen from other non-American jurisdictions is that you need to have robust testing. And a lot of our focus in recent months, appropriately so, went into testing because I think it was perceived as an area we were really deficient in early on. But I worry that that's actually been at the disadvantage of the other elements of good public health. So contact tracing, I fear we have not yet put enough resources and simply manpower into accurately being able to contact trace amongst our community. And following up from that needs to be a really robust method of quarantine and isolation when required. And so, you do see just a profound difference in the way jurisdictions have handled that recent cluster in Beijing, for example, where quarantine and testing and contact tracing has been their fundamental element of bringing that under control. We can't test our way out of this problem. That will not work. I can run all the tests in the world, and that will not stop people coming into the hospital simply by knowing that they're positive, without the other components of careful education, particularly in our communities that have been historically marginalized, or our Latino communities, for example, in North Carolina, are being substantially hit. Testing alone will not help without robust contact tracing. And we've ramped up a lot of numbers here in North Carolina, and I know other states have as well, but there's not a focus on that. There's not an acceptance that if I receive a phone call from a contact tracing organization that there's often a fear that that's invasive. There's a concern about what that means if I get put out of work for 2 weeks. Can I afford that? There's lots of elements to that I don't think we've really paid attention to. And maybe that was originally, I think, in the media at least, because there was such a focus on the testing failures that occurred here early on, that we've sort of forgotten about those other fundamental tenets of public health that are just as important. In fact, I would argue more so. We won't get this under control. We can't test our way out of it without those other things. Sallie, I'd be interested in your thoughts there too.
Yeah, I agree with all of that. I think there may have been a failure of health messaging in certain communities early on that we can fix now. Seeing that certain communities, like the Latinx community, is carrying a heavy burden for this virus, and also, contact tracing probably doesn't just mean contact tracing. It means providing resources that are going to be needed for that family to isolate, to potentially be out of work, to potentially be out of school. If we're in school, we can't let the education divide go even further because of this virus. And employers, I think, need to be educated also, and potentially provided with those resources to let their workers be out when there's been an exposure or an infection. And I feel like there's a lot more that could be shored up. Of course, it takes resources and funding, But at a time when we haven't seen a curbing of our infections, we have to do something different. And those are certainly areas we can improve on.
Actually, thank you both so much for that. To remind everybody on the call, you can raise your hands to ask a question or type one into the Q&A. Thank you for everybody who's already submitted questions. We're going to get to everybody as we can. I'm also combining questions as we've had so many. And so what I'd like to ask you both now is that nationally, we've seen obviously a lot of demonstrations and protests connected to the Black Lives Matter movement. We're also seeing maybe the return of large political rallies as the election draws closer. How concerned are you that these kind of events are going to prompt outbreaks in those areas, and how soon after those areas, after those kind of demonstrations and rallies and events, do you think that we would see the effects of that in terms of numbers going up?
Well, I can start. We know that it's important for our community to be able to have their voice heard, and especially in a time when we've seen a complete non-acceptance of the state of the systemic racism in our country. It is important to be able to foster that kind of community activism. However, as you say, when groups congregate together, there is a risk for this pandemic. One thing that I think is important for those types of events is to keep them outside as much as possible, because we know that being indoors with other people and talking and breathing with other people, those are the riskiest situations. And of course, requiring masks. Like Cameron said, there's more and more evidence that the masks actually really work in the community. So I think there are ways to have these rallies that are safer, at least, not completely without risk, but at least we can minimize the risk. I think if there is going to be indoor events, maybe as we come to the fall or winter, symptom screening and exposure screening before you let people in the building, adhering to the numbers that are going to be acceptable to our public health officials and our policies that are in place. So it's important to keep those conversations and voices going, but I think there are ways we can mitigate the risk, and of course, give some guidelines around how those individuals that have attended and feel they're at risk can get a test.
Gotcha, thank you. Dr. Wolfe, how soon would you expect to see any kind of rise in numbers based on kind of large gatherings like this? Is that something we should expect?
Yeah, it's a really tricky question, actually. I think if you look solely at the incubation period of the illness, it can be typically sort of 5 to 6 to 7 days before people start getting their symptoms. So I think by the time that people would present with symptoms acquired from an illness that they picked up at a protest, you're looking at a solid half to a week. The challenge is, I think it's not just the people who attend the protests who may, or any congregate activity for that matter, who can sometimes run into issues. I would think of sort of some of our large congregating activities on the beach in the same breath by saying that often the folks who are attending these activities are younger, and somewhat more healthy than, for example, their parents or their grandparents. And so I think you see a sequence of actually infections that run foul there. We've had a number of admissions in the hospital, for example, where maybe the triggering event was a congregate activity in a church or on a beach or a protest, but it wasn't until a second generation of infections occurred into family members who are at home or grandparents or at-risk individuals that we started to actually recognize that. So that's a long way around saying actually it's not that you can't quite map it out as saying the event happened on a Sunday and therefore I expect to see the numbers going up in my testing statistics or ED on a Thursday. What's clear is that it's not the day after, it's not 2 days after. There's a delay to this illness. There's a delay for the incubation. There's a delay, frankly, by when people present to the hospital. Unlike influenza, which causes people to get sick really quickly, this is a slow, drawn-out, protracted infection. And so oftentimes by the time people might present to an emergency room, it may be 2 weeks down the road from when they actually had their sort of inoculating event. So it actually becomes very hard to pinpoint when those infections, when those events or when protests or when a political activity, for example, will spill into the statistics. But just because you can't see it doesn't mean it's not occurring. I agree with Sallie. You can absolutely good leadership and good organization of these events will put into place mitigation strategies to prevent those sorts of transmissions.
Absolutely, that makes sense. Thank you very much for that. I'd like to get back to talking about hospitalizations. We've had a number of questions about that. And I'm wondering, it seems like North Carolina is maybe typical now of what we're seeing in the nation, since that early on, Governor Roy Cooper was lauded for his approach to this, but now maybe North Carolina is not doing so well. And Dr. Wolfe, I wonder if you can talk about broadly what you're seeing in terms of hospitalizations regarding, the symptoms and the severity that you're seeing, if they are similar that they were earlier or if things are changing, and how typical that is of what we're seeing nationally.
Yeah, it's a really interesting question, because despite hospitalization rates going up, that's not been quite the same with mortality in the hospital, reassuringly. In fact, I think we're probably doing a slightly better job at not only understanding how to manage someone who's sick enough to be in the hospital. We have some drugs now that have shown therapeutic benefit, such as remdesivir or maybe more recently dexamethasone. We understand ICU management of people with patients with COVID much better. I think the other part of it, though, is that we're not seeing quite the same extent of nursing home outbreaks that we did very early on in the pandemic. So for us here, for example, and true of other states, a very large proportion of the initial waves that struck our hospitals were older septo and octogenarians, people in their 90s who were getting sick because of their nursing home outbreak. And their mortality was high because of their comorbid illnesses and their age. That has substantially been replaced by us in North Carolina with younger, particularly Latinx individuals and community members. And maybe their upfront mortality is not quite so high, and maybe we're testing them a little bit sooner to get them into the hospital more efficiently than we did before. But we're not quite seeing the same inpatient mortality. So that we've had some gains, and we've not had complete success yet, would be my answer there. Sure, Sally, you're learning on the pediatric side too. There's big differences, clearly.
Yeah, I think what's different on our end is first that we have seen some hospitalizations for children and some even very severe and even deaths with this virus. But then what's different that we're watching is this post-infectious inflammatory syndrome, where we've had a few cases of hospitalization across the state, but it's actually a spectrum that we're even seeing in clinics and outpatient groups, that this is not just a spectrum of kids that land in the hospital from the post-infectious inflammatory syndrome, but there could be really a spectrum of disease presentation. So that's something we're still watching and learning actively from each other, from groups across the state, from groups across the country.
Dr. Permar, I'm glad you brought up that multi-system inflammatory issue, because are there things that parents who have children who have maybe been positive and weren't symptomatic and they didn't know it, are there particular things that parents should be watching for, or is it just your standard you're watching for high fevers and generally the kind of things that might affect children? Is there anything parents should be vigilant for and watching for that?
Yeah, what we have learned is those cases that have been most severe seem to be those that present to care late. And so I would take seriously high fevers, especially high fevers associated with GI symptoms. So that seems to be a primary presentation of the disease in children. So having diarrhea, potentially vomiting, and rashes. So that is another symptom that goes along with the disease. So I think the key is, like you would do with most childhood illnesses, if you have a high fever associated with other symptoms for more than a couple of days, you should definitely get in touch with your primary care provider and get evaluated for this syndrome. So there are ways that we can assess whether you have been previously infected with the virus using the antibody tests. It's actually probably the best use of the antibody test right now is assessing whether children are experiencing this post-infectious syndrome. And so now we know better how to treat it than we did initially.
Gotcha. Thank you very much. We've had one gentleman, one of our guests, Michael Hyland, who has been waiting patiently in the chat with his hand raised. Ivan, if you could unmute Michael, and you should be able to ask your question now.
Hi, how are you all doing this morning? I've got a question also related to the hospitalization issue. As we've seen that number steadily going up over the last several weeks, one question that I think we've struggled to get a clear answer on is, at what point is that necessarily a crisis point for the state? We get this number every day. We're told it's concerning. What does it mean in terms of us changing our behaviors, potentially going backwards on reopening? Can you give us some more context so we have a better indication of really what this means practically?
Yeah, sure. That's a really important question. So yesterday we had 846. If we had 846 admissions in March, that would have been a crisis, more than it perhaps is now. And I say that by inferring that we've actually learned a lot how to deal with that sort of wave worth of people in the last 3 or 4 months. North Carolina has been fortunate in that we've had a little bit of buffer of time to sort of learn how to structure our healthcare system in a way that not only can coexist with COVID, but can afford us the opportunity to do our regular things. We have to be able to deliver healthcare to pediatrics, to people who needed semi-urgent but not critically urgent surgery, and to do all the usual things that we do to keep our population healthy. I think though, where it comes down is that as that number continues to go up, there's a number of places where you may see stress into the system. You may see stress into the system in terms of intensive care bed availability. That's quite a fixed number that is shared amongst all hospitals across the state to understand where capacity exists. There's a bit of wiggle room in that can be factored in true surges. So for example, here we had modeled ways of having 2 infected people shared in the one room, for example, which is something we would never usually do, but can be a surge strategy to avoid absolute crunches. So spare ICU beds becomes a very important criteria. Nursing staff actually is one of the critical issues related to hospitalizations that becomes important for us to internally measure. And then frankly, even are there little differences within the state, within the regions of the state, as to who's experiencing issues. So Charlotte, for example, in April got very close to having to actually start moving people around within the state because of local ICU bed capacity really filling up. And so not just do we follow that overall number, although I think it's I still think it's the best statewide indicator that we have, but we also look at nursing availability, ICU bed capacity, and bandwidth to extend that, and sort of regional differences and how to, because Duke, for example, would be called on and we would respond to help if folks, for example, in the Triad or in the Charlotte area realized their bandwidth was stretched. How you flex that is something that we've also learned a lot about. And I think for us, what that has meant is to put plans in place to reconsider, and hopefully we never get there, but reconsider closing back down certain clinics to free up staff space, or to, again, go back through surgical lists, heaven forbid, to understand who is really urgent or who can be deferred. Now, they're not decisions that you take lightly, because there's cost physiologically to the community from their health, and there's also extraordinary costs to healthcare systems for sort of modifying their business in that sort of crisis fashion. So we look at that number early to try and understand, are we going to run into a problem in the weeks to come, put it that way.
Okay, thank you very much.
Make it a more Duke-specific answer and say that currently we have 84 patients in the hospital system for us, and that number's bounced in the low 80s for the last week or so. We think we have a decent amount of flex still in the overall number of beds, but if that number were to creep up into the well above the hundreds, then you start really having to weigh in to say, hey, maybe we need to look at tailing back here to operationally make it safe for us to care for people.
Got you. Thank you very much for that, Michael. I hope that answered your question. Another question we've had come in the Q&A is this concern about seasonality. Like, how concerned are you that come the fall, we may see, regardless of our behaviors, or perhaps alongside those behaviors, a resurgence like we saw in the spring, and that we may end up having to close down just because of a seasonal resurgence of the virus?
Yeah, so I can start with that one. It's still, I think, an unknown, what seasonality is going to have as an effect on this, the trajectory of this pandemic. I think that that surge in the fall when we think of most respiratory viruses, has to do with the seasonality of viruses like influenza, respiratory syncytial virus. And they often are tied to children congregating again in schools, also tied to the colder weather and people being inside together more often for longer periods of time. And I think because we have seen different trajectories of this pandemic based on what measures have been put into place, the social distancing, et cetera, it's not yet clear we're going to have more of a surge in the fall than what we're experiencing now. And so while one thing that we know will happen with this virus coming into the fall is it will start to intermix with cases of other respiratory viruses that we expect to take hold come the fall and the winter, like influenza. So instead of being able to consider this as one of the primary respiratory viruses that we're thinking about in patients who are presenting with symptoms, we now will have to think about a host of viruses that could be impacting the population at the same time. So I think it will get more complicated in the fall because of those other respiratory viruses, but I don't know that we know what the trajectory of this virus is going to be, whether it will keep creeping up like it's been doing for the past few months in our community, or whether we'll have a big surge, or whether it'll be steady. But I think we know it won't go away, and it'll start to be intermixed with other viruses.
There's practical implications to the way that plays out, though. I'm glad you mentioned flu, because there are some of those that we have interventions for, don't we? Like we have a flu vaccine. We don't yet have one for COVID, but the way we've taken that message on the university side is to say, I don't want to have to quarantine people because they got the flu unnecessarily, and I can't differentiate it up front as to whether that was COVID. So for us, it's been a big drive to, in fact, re-expand our requirements for flu vaccines as August and September comes along, to try and really minimize that sort of co-infectivity. And it's not just that they co-circulate. I'm a little bit anxious that they can ramp each other up, because if I'm sick with the flu and I'm already then starting to cough and expectorate and sneeze a little more, what a sort of perfect environment for sort of mixing of respiratory viruses. We've not seen that yet. Actually, you could look at the Australian example, and influenza has really dropped away because they've been quite effective at putting into place masking and social distancing that is effective actually for all respiratory viruses. But like we started this whole conversation with, we've been pretty fatigued with doing that as a community. And therefore I worry that, if you look at how well we'll be doing in 3 or 4 months' time, we will really need to have had a significant sort of phase change or cultural shift to move towards more consistent masking, more consistent recognition of social distancing being appropriate to block a later surge.
And that seems to be tied to this notion of leadership you mentioned earlier. Have you seen any states in the US you've been really impressed with their approach to this, that you feel have handled it well? North Carolina seemed to be doing pretty well to begin with, but then maybe things have dropped off based on hospitalizations. But what states are working this well, do you think?
I think that the reactions have been very different because different states have come into this at different paces. Like Massachusetts, for example, have now put in very early on large-scale contact tracing efforts and sort of masking efforts. But also they faced the brunt of an earlier epidemic, and so I think we're in a position where they were forced to really think about those changes. I would view North Carolina as we should have had the luxury of viewing everyone else having the brunt of a big COVID wave in March and April to get ready for those sorts of changes, and yet we've not really forcibly done them yet. I don't know if I can highlight one particular state as having stood out to me, but
sure,
Sallie, you may have a sense of.
Well, I think watching New York, go through probably the biggest strain on a healthcare system, and just some horrific, stories that came out of that, and then to have continued drop in cases, since they reached their peak sometime in April, is impressive. They've been extremely slow in reopening, and of course there are a lot of people in New York City, of course. So I think that is an example that those measures that are put in place can really work even when you're at the brink of overwhelming your health system. But it'll be interesting to watch now that they'll start to reopen.
Great.
Thank you both for that. You've both mentioned vaccines. Obviously, there are multiple efforts on multiple fronts going on worldwide. But Dr. Permar, I wanted to touch on what you had mentioned about why you feel it's so important that children should be involved in the development of a vaccine. Why is that so important to the work to try and eradicate this disease?
Yeah, so it's really exciting actually to be in the vaccine field and watch all the technology and the immunology and the different platforms for vaccines really come together, and the collaborations come together at this time to rapidly put out not just one vaccine candidate, but many vaccine candidates, because we know that any one could have a problem along the pathway to being licensed and getting out to individuals, and there'll be another one right there behind it to be useful. So it's an exciting time in vaccine development, and I think, rightly so, all of the safety measures are being looked at in adults, the testing to be sure that these vaccines don't cause some reactions after you get them, but also importantly, what happens when a vaccinee gets exposed to the virus? Do they fight off the virus, or are there some effects of having that vaccine immunity that may lead to some disease we didn't expect? And so those, are rightly so going forward in adult populations. And even we know that adults are the ones who are landing in the hospital most often and who are facing mortality most often. And so those are going to be the individuals where it's rolled out first. However, I think what will be a mistake is to wait until we have every adult vaccinated to then start thinking about children. And there are some big advantages to developing a vaccine that could eventually be targeted towards children. And that is, again, that the pediatric vaccination schedule is by far the most successful strategy that we have to get very high coverage of a vaccine in a population. So pediatricians are extremely good at getting vaccines to their patients, whereas we don't really have those systems for adults. And so, some of our best working vaccines, like the flu vaccine, the HPV vaccine, they don't even reach, half of the people that we want to get vaccinated, who are adolescents or adults and older. And so it has advantages there. Also has advantages that many of the vaccines we give in children develop immune responses that give you immunity your whole life long. So some examples are the hepatitis B vaccine, the tetanus vaccine, that you get long-term benefit of immunizing early in life. And that partly is because children and infants and toddlers are actually very good at making certain types of immune responses. And those are the types of responses we're looking at to prevent this virus, those antibody responses. And so there could be advantages that if we give the vaccine early, you actually get long-term immunity from the vaccine. And then finally, that children haven't been completely unaffected by this virus. There have been pediatric deaths, there have been pediatric hospitalizations, and now we have this inflammatory syndrome that we think could be prevented by vaccination. And so, and further than that, kids often are the spreaders of respiratory viruses to adults. And so shutting down routes of transmission through vaccinating children, I think, will be important. So it's a plug to make sure that we think about children and not exclusively adults, as often our therapeutic pipelines are targeted towards, but to remember children and all the advantages of immunizing children in this pandemic.
You're amazed at the science, and so am I, but I'm also amazed at the sort of the transnational effort on the logistics end to think about ways of producing those vaccines. So it's one thing to singularly focus all vaccinology science on coming up with these products, which has been incredible in itself. It's quite a different thing to imagine how you can logistically produce many billions, frankly, of vaccine doses in a timely enough fashion to turn down a pandemic. And that can't rely on one country, that can't rely on one company, that can't rely on one factory. And so to see sort of multinational groups, the WHO, sort of European Union, really thinking about ways of creatively guaranteeing that can happen, even such that you have companies starting to ramp up productions of vaccines that they're yet to prove work, in order to guarantee that they can then have sufficient production capacity to allow them to produce en masse is unique. That's an unprecedented effort. But that does also require a lot of transnational cooperation. And
I'm glad you brought that up. I'll just let everybody know on the call that our media briefing next week will actually be on the testing and production and widespread manufacture of vaccines. So you can certainly join us for that if you're interested. An uncomfortable question here that I feel like we have to ask. You know, in recent years, before the pandemic, there had been this growing kind of anti-vaccine movement that had led to measles outbreaks here and there. Are you concerned that that could affect the penetration of a vaccine? Or do you think the seriousness of this outbreak and the way that the world has been confronted with it will actually help kind of maybe eradicate that anti-vaccine movement or squash it to where it is no longer an issue for public health?
Really good question.
Yeah,
Yep.
both of the above. My hope is for the latter. I'd be naive not to be concerned about the former. And I think it is going to be really incumbent upon public health leaders and federal government leaders to demonstrate a clarity of message here that needs to be uniquely available and visible to the public, to say that there's, you know, to demonstrate safety, to recognize the science once it gets to a point when we're confident about it, and to make it clear as to why there is a community and personal benefit to this vaccine once it becomes available, if it becomes available, let's be honest. So yes, I am worried about skepticism. I think we have to be aware of that when we're moving forward with this. And we have to continue to try and reiterate active demonstrations of safety of that and show real leadership. Sallie,
Yeah.
you're in that all the time.
Yeah, I would say that I do hope this is the golden age of vaccines, that every single person on this earth has seen their life upended because of one virus. And we have the power to stop viruses like that, but it requires vaccine science. And luckily, we have that capability. And you see it pumping out right now, you know, what's going to be several candidate SARS-CoV-2 vaccines. And so I do hope that there'll be renewed emphasis on vaccines. However, what I see as a risk is that the safety of this vaccine, or the number of candidates of this vaccine that that come through the pipeline, that we have to be sure that they are safe. Because if we roll out a vaccine to a large percent of the population and then have a safety concern, that will, I think, diminish the faith in vaccines. And so while we're going at this with the most rapid speed, because the pandemic is not ending probably until we have a vaccine, we are also facing the challenge of making sure it's the safest vaccine that we can put out in a rapid fashion. And so I think the FDA, all the way down to scientists, to public health leaders, need to really consider the safety of each of the candidates that comes out, and you know, head off any problems before they become widespread.
And also make sure once it's rolled out that we don't immediately drop off on our contact tracing and on our masking and other mitigation strategies, because there's no way that this will be a sort of a light switch moment. We can't, like, yes, I think we all hope for a vaccine to be the panacea that makes this pandemic go away, but in reality, it's gonna be one of many ongoing elements.
Thank you both for that. And we're getting towards the end here, and I want to cram in as many questions as I can. But I'm glad you brought up the contact tracing aspect of this, because obviously, you know, there are some parts of the world that have been doing this well. In the US, it certainly isn't widespread. Are you encouraged by what you're seeing? Do you think that we are starting to build the kind of capacity nationally that we need, or do you feel like it's still just way behind where it needs to be?
Well, we've certainly improved. You know, there's been lots of states that have put in significant amount of funding and resources to try and really build a strong contact tracing army. You need a lot of people. You know, because this virus is so slow, because the symptoms for so many people are so minimal, you come into contact with a lot of people. Look at the earlier example that we said of 2 hairstylists needing to contact trace 140 people who came through their building. This is a lot of manpower, and I think it's better. Are we at a point where we feel that we've got enough? I know North Carolina does not feel like we have enough. You know, we've even tried to sort of internalize that in a microcosm of the university campus and say, you know, what happens when we bring back thousands of students and their professors and teachers? What does that look like from our contact tracing ability? And we need dozens and dozens of people in that space capable of doing that. So I think there's lots of improvements to be made, but I think it's now starting to be recognized, like we said earlier, that we're not going to test our way out of this problem. We have to have good contact tracing systems put in place. They're not there yet.
Gotcha. Thank you. Okay. I want to kind of zoom in on some personal decisions that people are having to make right now. As we've moved through reopening, people are looking, families, as you said, Dr. Wolfe, earlier, people have been a bit jaded about this, got a bit complacent, but people are now looking at summer. People want to go on summer vacations, or people want to do day trips. What kind of factors do you think parents and families should be weighing nationally when they try to decide whether to take that trip to the beach, to get in the pool, to go on vacation? What are the top considerations people should be thinking about when they make those decisions?
Yeah, so that's a question that I get all the time, and questions that go through my head constantly on, how should I be facing this risk with my family? And I think you do have to weigh and assess your own risk within your bubble of the people that you interact with. So if you live with an elderly person, or your kids visit their grandparents often, you may want to think about not exposing them to the extent that is allowed right now. Like I was giving the example that my family made a plan to not go to the pool this summer, not go to the public pool. And we bought one of those blow-up pools for our backyard. And, when you think about going on a vacation, and it's going to be with other family members or maybe with friends, can you quarantine yourself for 14 days beforehand so that you go into it feeling good that when you interact with those people, you're not going to be putting them at risk? And so there is a lot of personal risk assessment, I think, that goes into assessing how you're going to plan out your summer, and just know the principles of wearing a mask, keeping yourself 6 feet away from people that you can't be sure whether they have the virus or not, and minimizing the amount of interactions that you have to have. So we know the principles, and I think just assessing your own family for the risks you're willing to take on.
I'll give you two examples of what we've done, if this serves as a good story. The first was that we took a decision amongst our family. I've got a lot of in-laws in the sort of Midwest of the country. And, some of those are grandparents of my children who are in their mid-70s and medically more frail than they had been 10, 20 years ago. And so we took a decision to say, look, North Carolina is in a ramping up phase of this illness. I don't want my kids or my wife and I to have exposed, to inadvertently expose elderly individuals in our family to COVID unbeknownst to us. So we have not taken a family holiday out there this summer as a direct result. Conversely, we took our first decision to go out to a restaurant on the weekend, and yet we made an intentional business purchasing decision to choose a restaurant that visibly had spacing, had their employees wearing masks, were prepared to advertise to the fact that they were having adjustments because of COVID that kept us safe, and that we tried to keep them safe. And we walked past a few that were not doing that. And so I think, we would like to think that we can let our money talk when it comes to making purchasing decisions, to be supportive of businesses that are making wise choices on my family's health behalf. I think there's lots of avenues where you can do that can set good examples.
Absolutely. Thank you both for that. We've just about reached the hour mark, so we're going to wrap this up. But I have one closing question for both of you, and it's a very blunt one. There are a number of states across the country, North Carolina, Texas, Georgia, Florida, who, as you mentioned, Dr. Wolfe, are still in a ramping up phase, but they are reopening. Do those states need to roll that back? Do they just need to go back to phase one, or is there a way to stay where they are or continue to move forward safely?
I think being prepared to put a pause on things should be the first step to that. I'm heartened that our state health departments are finally talking about the implications of what a pause to phase 3 for us would look like. If we consider ourselves to be data driven and we see our data heading in the wrong way, it's nonsense to think that we can continue doing the same thing and expect that trajectory to change. So but that said, I think re-crunching down can be still avoided if you put your efforts into the right sort of mitigation strategies. So, you know, there was a question here on the sidebar about the consideration of masking at a governor's level. I think that's a rational choice. You know, maybe that's what people have to get used to accepting, of the fact that is, if you want to keep opening and if we want to allow businesses to function, an individual choice on behalf of our collective for me to wear a mask seems like a downside smaller move and something that's easier than having to crunch back down and shut everything down again. So yes, it's important to look at your data. Yes, it's important to use that to rationalize decisions about reopening. But I do think you can prevent the reclosure if you focus efforts on contact tracing and good public health. And so, you know, I was proud of Orange County, for example, near us, to come out, and I think Wake is entertaining doing the same thing if they haven't already, to join Durham in making a countywide requirement for masks. I think that's entirely appropriate and hopefully allows businesses to stay open.
I'll just second what Cam said, that you know, those number of ICU beds is really our absolute. And I think when we're reaching a threshold where hospitals can't handle the number of patients they have, then drastic measures do need to be taken. But if not, we should look for ways that we can learn to live with this virus, yet still keep our economies open. But it's going to require behavior change on the part of our communities. And that starts from leadership, and it starts from education. And so I'm proud of our state for continuing to keep an eye on the data. That's one thing they're very committed to. And I trust in them to make decisions that will be based on the data and based on the new knowledge that we learn about the virus, including the importance of masking.
Behavior change is hard though when you're not visibly impacted by this in a way that you can see. Most of us, apologies, the lights have gone off in my room. Most of us who don't work in healthcare have been fortunate not to have had personal experiences of loss or severe illness due to COVID. We were not like New York. And so it's hard, therefore, for people to grasp why a mask makes such a big difference when you may not have had a personal experience with this other than the social and financial implications of job loss and closures. So I get the fatigue. I totally understand that. And some days I wish I could just take people and walk them through my ICU just to show them what devastating COVID can actually be. But that doesn't mean we can't still have good leadership that really publicly is data-driven and is visible in their mitigation efforts. And I think that will help us keep open.
Absolutely. Thank you both so much. I think we'll call it there. Thanks everyone for joining us. If you are just joining us, the gist is wear a mask. Thanks so much to our panelists, Dr. Sallie Permar, Dr. Cameron Wolfe, for sharing their perspectives. Thanks for reporters for joining us. Our next briefing, as I mentioned earlier, will be next Wednesday, June 24th at 10 a.m, when we'll be discussing ongoing trials of vaccines for COVID-19 and the development and manufacture of those on a wide scale. If you'd like to be included on that advisory, please email dukenews@duke.edu. In the meantime, thank you everyone for joining us, and please stay well. Have a great day.
Thanks so much, Greg.
Thank you. That was great.